Continuing our discussion of the fluid and electrolyte disturbances, we are going to discuss sodium abnormalities now. Sodium, as you know, is the major extracellular cation and it is very strictly regulated. I want you to understand sodium abnormalities as the water abnormalities. Whenever there is any water abnormality, it will eventually affect sodium. So hyponatremia, as the decrease of the sodium, the plasma concentration in which the plasma concentration of sodium is decreased, is generally because of excess of water. Now, this can be because of a lot of reasons, but the major players involved in it are the ADH or the vasopressin hormone or the ingestion of the free water. So anyone who has hyponatremia because of any cause, which we are going to see in details, the various types and the various causes of hyponatremia, at the bottom of it is some water disturbance, which leads to an increase in the overall water content of the body, and that leads to dilution of the sodium or the loss of the sodium eventually in less proportion as compared to the greater loss of water. So this leads to hyponatremia or the decreased plasma sodium concentration. So let's get into the details of our today's topic, hyponatremia. As you know, the normal plasma sodium concentration is between 135 millimoles to 145 millimoles. So hyponatremia is defined as the plasma concentration of sodium less than 135 millimoles. To have a better understanding of the various causes of hyponatremia and to have a good parameter for evaluation of the causes of hyponatremia, we are going to break down the evaluation of hyponatremia or the causes of hypovolemia into two major steps. The number one step, whenever we have a patient with hyponatremia, the number one step is to evaluate that whether the patient's osmolality is truly low or not. That is, whether the patient is hypotonic or the patient is isotonic or it is hypotonic. So, because the osmolality gives us a really good indication of the overall content of sodium. As you know, the plasma osmolality is generally calculated by the following equation, 2 times the sodium concentration plus the glucose divided by 18 plus the BUN or the blood urea nitrogen divided by 2.8. This generally gives us a figure of around 280 to 290 milliosmoles per kg of water. This is the normal plasma osmolality. Now, whenever we have a case of hyponatremia or anyone who presents with a decreased sodium concentration, first with the help of this calculation, we find out that whether the hyponatremia is a true hyponatremia, which means that along with the sodium, the overall osmolality of the patient has gone down, which means the patient has hypotonic hyponatremia. Because there are some outliers as well. For example, if we have a patient with decreased sodium concentration, and then we plug the various figures of glucose and the sodium concentration and the blood urea nitrogen into that equation, and the overall osmolality of the patient comes out to be normal. Now that is a condition which is generally described with the term pseudohyponatremia, and it basically is a lab error. In certain labs, when they calculate the sodium concentration, they can give you a false negative value in which the sodium concentration given by the lab is less, but when you put out the various variables in the equation, you find that effective osmolarity is within the normal range. This condition is generally called pseudohyponatremia, and it is very important first to rule out that whether this hypotonia or the hypoosmolality is true or not. So whenever we have decreased sodium concentration, the first step is to put the values of the sodium, BUN and the glucose values, and to find out the actual osmolality of the plasma. Once we have ruled out the pseudo-hyponatremia, then we have to also look at the other variables, that whether this hyponatremia or the hypoosmolality is because of sodium or the other players in the equation, like glucose or urea. There is a condition which is called hypertonic hyponatremia, in which overall osmolality of the patient is high, but the sodium value goes down to compensate for the increase in the other variables. For example, in someone with uncontrolled diabetes who has a lot of plasma glucose going on, or someone who has uremic symptoms going on, and the BUN and the creatinine are through the roof. In such patients, when we calculate the overall osmolality with the equation of the osmolality, the overall plasma osmolality will be high. And to compensate for the increase in either glucose or the BUN, the plasma sodium concentration goes down. Now, clinically or with the categorically, you can define that patient in hyponatremia, but the osmolality of the plasma is high. So these are the two variables, the pseudo-hyponatremia and the hypertonic hyponatremia, which we have to first evaluate whenever we have a patient with hyponatremia. So if we have low sodium concentration and then we put the variables of sodium, glucose and BUN in the equation of the plasma osmolality, and we find the plasma osmolality less than 280 milliosmoles per kg, then we truly define as that this patient has hypotonic hyponatremia or the true hyponatremia. Once we have established the hyponatremia, then the next step is to look at the volume status of the patient. This is very important to understand that the sodium concentration gives us very little idea of the overall volume state of the person. Person might be hypervolemic, he or she might be euvolemic or hypervolemic, because water eventually follows sodium, but water can evenly distribute among the intracellular and extracellular compartments. So the overall volume status of the patient is very sodium is a very poor indicator of the overall volume status of the patient. And then we have to evaluate that patient according to the overall volume status. Based on the volume status, we have classified hyponatremia for our diagnostic ease into either hypovolemic hyponatremia, in which the overall volume of the patient is low along with the sodium, or the euvolemic hyponatremia, in which the sodium concentration is low but the patient is euvolemic, there is no volume deficit. And on the other spectrum, there is hypervolemic hyponatremia, in which despite being the sodium concentration, plasma sodium concentration being low, the overall volume status is high. The patient is overall volume expanded. For hypovolemia, we use the term volume expanded. For hypovolemia, we use the term volume deficit, or in medical terms, in routine medical terminology, we can see in hypervolemia, we can say the patient is wet. There will be a lot of symptoms of edema and swelling throughout the patient. And in hypovolemia, you can say that the patient is dry, that the patient's blood pressure will be low, there will be tachycardia, or eventually the symptoms of the patient going into shock. The mucous membranes will be dry, the patient will have increased thirst, and the extremities will be cold. And euvolemia is basically the patient will have a normal volume concentration. So this is for the diagnostic ease. And now we are going to look at the various causes of hyponatremia according to the volume status. Now we have to assess the volume status. In hypovolemia, as you know, the overall water content and the total body sodium goes down. So hypovolemia, what can be the various causes of hypovolemia? As you know, we have classified the volume of the causes of the hypovolemia according to the renal and the non-renal causes. If the patient has the number one marker of indicator of the volume is in this context is the urinary sodium concentration. If the kidneys are working fine, then the kidneys will be able to conserve the water because of decreased volume, and the renin-angiotensin and the aldosterone system will be activated, and the kidneys will be able to conserve the sodium. This will lead to very little sodium loss in the urine. So if the kidneys are working fine, then the patient will have decreased urinary sodium excretion, preferably less than 20 millimoles. But if there is some kidney issue going on and the patient is hypovolemic, then the urinary sodium concentration might be greater than 20, which indicates that the kidney is not preserving the sodium according to the normal requirements, which it should be. So what can be the various causes of leading to increased sodium loss in the urine? If the urinary sodium concentration is greater than 20, then think about any abnormality in the kidney. There might be some renal losses. For example, the patient might have tubulointerstitial disease. There are some tubular problems going on. The tubules are not effectively, the proximal tubule might have necrosis, or the patient might be taking some drug like the tetracyclines or like the penicillins, which might have affected the patient's proximal tubular sodium absorption capacity, or either the other parts of the tubule, like the distal tubules, might be affected. So the renal losses are the number one causes of increased sodium urinary sodium concentration. So There can be some diuretic excess. The patient might be taking thiazides, for example. These are the most important in this context to understand. Mineralocorticoid deficiency, like primary aldosterone deficiency, primary hypoaldosteronism, leads to hypovolemic hyponatremia. This is very important to understand. In the absence of aldosterone, the sodium will be lost in the urine. So the urinary sodium concentration will be high. Similarly, there might be some salt-losing nephropathies, like, as I mentioned before, some tubulointerstitial disease or some tubular deficits, or in the recovery phase of the acute tubular necrosis, as we know that the patient has a very high natriuresis or diuresis, and this leads to loss of salt, and this can temporarily cause hypovolemia as well. Similarly, if the patient is losing bicarbonate in the urine because of any proximal tubular reabsorption issue, or if someone who is diabetic or someone who is starving and has DKA as well, ketonuria, with the increased loss of ketones, there will be increased loss of water along with the osmoles, the osmotically active substances. This will lead to hypovolemia, and this will also wash off the sodium. Similarly, there is a condition called the cerebral salt wasting syndrome. This is a very rare pathology. In this condition, what happens is any abnormality in the brain, for example, any infection, for example, meningitis or hydrocephalus or any brain injury, brain tumor, can affect the kidney's ability to conserve sodium. So in those patients with a head injury, we have to rule out the cerebral salt wasting syndrome. The patient will have hyponatremia, the patient will be hypovolemic, along with that there will be some loss of potassium as well. This is a rare entity which should be kept in mind when evaluating for hypovolemia, especially in the context of someone who has had intracranial hemorrhage or recent surgery of the nervous system, or has had any neural pathology in the recent history. These are effectively the renal causes. Let's go on to the other side and see if we find out on urinary sodium that the urinary sodium is less than 20 millimoles, which means that the kidneys are doing their job very well, and the cause of the hypovolemia is outside the kidney, or these are the non-renal causes. So anything that can decrease the plasma volume, be it hemorrhage, or if we go into the GI tract, this might be vomiting, diarrhea, or with the help of any suction of the GI tract we do with the excess of it. There might be third space loss of fluids, for example, someone with pulmonary edema as well. The burns, or a patient might have lost their integrity of the capillary endothelium, and this can lead to third spacing of the fluid. In someone with pancreatitis or trauma, this can happen. The major causes being the hemorrhage and the GI tract loss, or the insensible water losses, like someone who has been running a marathon and has not actively rehydrated himself. So based on the urinary sodium concentration, we divide the volume hypovolemia causes into renal and the extrarenal causes. If the patient is clinically euvolemic, if there are no signs of a dryness or no signs of volume overload like edema, then this is classified as the euvolemic hyponatremia. In this, the total body sodium remains the same, but the total body water content has increased. The increase of the total body water has conserved the volume of the patient, but this might lead to dilutional hyponatremia, or because of any problem with the loss of the sodium, there might be hyponatremia. To remember the causes of the euvolemic hyponatremia, I want you to remember this with the mnemonic RATS, R-A-T-S. The urinary sodium will be definitely greater than 20 in these patients as well, because as you know, the kidneys will, because of the various causes which I'm going to mention, in which you see that the kidneys will be losing greater sodium. Now, as we are talking about the mnemonic RATS, for R in the RATS mnemonic stands for renal tubular acidosis. A stands for Addison's disease, especially secondary Addison deficiency. Then T stands for thyroid disorders, hypothyroidism, and S stands for syndrome of inappropriate ADH, or SIADH, and it also can stand for stress, as it is mentioned. So, renal tubular acidosis is not mentioned here in detail, and that will be discussed in detail in the coming lectures. Let us look at the other abnormalities. Now, I told you that A stands for Addison's disease. Preferably, this is the secondary Addison's disease, in which there is some abnormality in the pituitary, which has led to the deficiency of aldosterone and cortisol. In the primary mineralocorticoid deficiency, or the primary Addison disease, which is at the level of the adrenals, I want you to remember that that causes hypovolemic hyponatremia. as mentioned here in the renal part. The secondary addition disease, in which there is a glucocorticoid deficiency along with the mineralocorticoid or the aldosterone deficiency, that leads to euvolemic hyponatremia. Now, there is a reason for that. What is the reason? That if you remember in the normal physiology, glucocorticoid generally has a negative feedback on ADH or the vasopressin. So whenever there is glucocorticoid deficiency, for example, in secondary additions disease, the ADH will be disinhibited. And that disinhibition of ADH clinically creates the same condition like SIADH or the syndrome of inappropriate ADH. The ADH will be in excess. That leads to pure free water absorption and the sodium will be lost in the urine, and that leads to euvolemic hyponatremia. Similarly, if there is any thyroid abnormality, hypothyroidism especially, that leads to this euvolemic hyponatremia. Stress can cause this, and the major or the number one cause of euvolemic hyponatremia in our setting, medical setting, is the syndrome of inappropriate ADH or SIADH. This SIADH, as you know, there are million causes of this SIADH. A large number of causes can cause SIADH. There might be some drugs like the cyclophosphamide or some tricyclic antidepressants that can cause that. There are certain pulmonary pathologies like pulmonary infections, tuberculosis, pneumonia, a lot of malignancies, especially the small cell carcinoma or the mesothelioma causes pulmonary ADH inappropriate excretion. Similarly, a lot of nervous system disorders like any history of trauma or brain malignancy that can affect the ability of the ADH to be inappropriately secreted. So SIADH or syndrome of inappropriate ADH is the number one thing which we have to manage when we have a patient with euvolemic hyponatremia. So moving forwards, if on clinical evaluation we find that the patient is wet or the overall the patient is in volume excess, the patient has edema, the patient has pitting edema, you can hear the rails on the auscultation of the chest, that means that the overall total body water concentration is very much increased as compared to the sodium concentration. So this leads to a condition called dilutional hyponatremia or hypervolemic hyponatremia. And this is because in this condition you can see that the sodium concentration is high, but the patient is hypervolemic, and this in excess of the sodium concentration. So on examination we'll have hyponatremia, but the patient is in volume excess. That's why sodium is a very poor indicator of the volume status of the body. What are the conditions that can cause hypervolemic hyponatremia? Again, when we evaluate this, we have to look at the urinary sodium. Urinary sodium gives us a very good indication of, after evaluating the now the three steps which you have to understand. The first thing is to evaluate the true osmolality. With the help of that calculation I told you before, you can find out the plasma osmolality. Now if the patient is truly hypotonic or hypoosmotic, then the next step is to assess the volume status. You clinically assess whether the patient is hypervolemic, hypovolemic or euvolemic. After the clinical assessment, we look at the urinary sodium concentration, and afterwards with the help of that calculation we further classify the patient's cause of hyponatremia. Now, if clinically the patient is hypervolemic and we evaluate the urinary sodium and the urinary sodium comes up to be high, this means that the kidneys have some issues going on. And in this condition, especially the renal failure, either it is acute or chronic, that can cause increased urinary sodium concentration and overall hypervolemia. If the urinary sodium concentration is within limits or less than 20, then this is the general syndromes which lead to the third space fluid loss. For example, the conditions which we discussed in edema, in which there might be some alteration of the Starling forces like increase in the plasma hydrostatic pressure or decreased oncotic pressure, that leads to an overall generalized edema or the hypovolemia in the patient. The important ones here to mention are the cardiac failure or liver cirrhosis and the nephrotic syndrome. In liver cirrhosis, you know that the liver is unable to make proteins, which leads to decrease in the oncotic pressure. And also there is a vasodilation, this splanchnic vasodilation, which leads to an increase in the Starling forces. In the nephrotic syndrome, the patient will be urinating a lot of proteins, and it leads to a decrease in the plasma oncotic pressure, and that leads to loss of the fluid in the interstitium or the third space fluid loss. And the cardiac failure, in cardiac failure, the patient is unable to pump out enough adequate blood to effectively circulate or to have an effective arterial circulation. And then all of these conditions in turn generally lead to an increase in the renin, angiotensin, aldosterone system, and then the whole plethora of steps, as we know, the angiotensin 2, aldosterone, they all get activated and overall lead to a hypervolemic state. So this is a very important flow chart to understand the various causes according to the volume status of the patient. And you'll see further that based on our diagnostic evaluation and even the treatment regimes, this is the flow chart which we will always keep in mind to look at the various diagnostic modalities we have to use, or to look at the various treatment options we have. Now, apart from these causes in which there might be some volume abnormality, another important cause of hyponatremia is the low solute intake or the low sodium intake. This specifically occurs in alcoholics, because as you know, the alcoholics, their whole diet is the beer or the alcohol, and this is even classified as beer protomania, a condition. As alcohol is very much deficient in solutes, especially sodium, the patient, someone who is a chronic alcoholic, has a low solute intake, and over a period of time that leads to hyponatremia. Clinically, or what are the labs which we are going to have? The patient will be malnourished, as you know. The patient urinary osmolality will be very low, less than 100 milliosmoles per kg. The patient will be secreting a very dilute urine. This is because despite the increased alcohol intake, the patient will be dehydrated, because the patient will be drinking less water, and ADH will be increased to conserve the patient's hydration status. And along with that, the urinary sodium concentration will be very less, like less than 10 to 20 millimoles. And this is because of the low solute intake. The kidneys are trying to preserve as much sodium as they can. So the sodium concentration and the urinary osmolarity both are low in someone who has not been adequately taking sodium. Or this might happen in someone who is strict vegan and avoids sodium and meat strictly. And because of this decreased urine osmolality and decreased urine sodium concentration, this will limit the water excretion, and the ADH will be increased. And this can also lead to dilutional hyponatremia in these patients as well. So this is another important cause to remember when we are evaluating the patient. We have to look at the overall patient's nourishment, whether there is a high alcohol history as well, or the patient's dietary habits, whether the patient is a strict vegan or not. Now, as we have evaluated the various causes, now let's talk about what is acute hyponatremia. Acute hyponatremia is basically hyponatremia developing within the 48 hours. 48 hours is the cutoff which we have set for the hyponatremia to be either be acute or chronic. Any hyponatremia which develops over the 48 hours period, we classify it as chronic hyponatremia. Less than 48 hours, we term it as acute hyponatremia. What can be the various causes that can lead to a very acute or a very quick sodium loss or the sodium dilution? The important ones are to remember are the iatrogenic causes. For example, as you know, after any surgery, what happens is surgery is a stressful state. So the body tries to, after any stress, the stress hormones are activated. There will be an increased cortisol secretion, there will be an increased thyroid concentration, and similarly ADH will also be increased. So because of an increase in ADH post-surgery for 1 or 2 days, the body has in excess of free water. And in those patients, if we don't give enough salt to those patients, or if we infuse those patients, especially with hypotonic solutions, like half normal saline or dextrose water, more than what is required by the patient, then this patient post-op can develop acute hyponatremia within 48 hours. This is especially evident in post-op premenopausal women, for reasons unknown, that premenopausal women compared to men are more prone to developing this acute hyponatremia. Similarly, as I told you, hypotonic fluid insertion with increased vasopressin already can lead to acute hyponatremia. If someone is having a transurethral resection of prostate and we irrigate that with the help of glycine, or in uterine surgery you give any extra osmolar fluid, like you irrigate the patient, you irrigate the uterus or the prostate with a glycine or some osmolar solution, then that can lead to depletion in the sodium concentration and the overall increase in the osmolality of the extra solutes. So in patients, especially the TURP or the post-uterine surgery, we have to be very careful with our fluid balance and what we are giving to the patient. We have to monitor the urine output as well and the sodium concentration for the first 48 to 72 hours. Similarly, when we are preparing a patient for colonoscopy, we wash the gut away, and if we are using glycine or any other substance that gets absorbed in the body, that can also lead to dilution of the sodium and excess of the water, and clinically can present as acute hyponatremia. If someone is using thiazides, then thiazide usage, especially in a few prone patients, can lead to a condition of hyponatremia, and it can develop acutely. And this is also very important, because whenever we are managing a patient with hyponatremia, we have to rule out the 2 or 3 basic things before going on to the further common causes. Like we have to look at the creatinine, whether the patient has renal failure, and we have to look at whether the patient has recently taken thiazide or if there is any history of thiazide intake. Because thiazide can lead to sodium diuresis, and this can also lead to hypokalemia as well. And with the loss of increased sodium, the patient might develop acute hyponatremia, especially if the thiazide doses are very high as compared to what normally should be the patient should be taking. Similarly, polydipsia, because of any cause, if the patient is drinking a lot of water, whether may it be psychogenic polydipsia or just because of any other reason, this patient can develop acute hyponatremia, especially if the water intake is too much or too adequate that the body is unable to manage it. A drug called MDMA or ecstasy, this is a banned substance or some addictive substance. This can lead to loss of a lot of sodium in the body, and the patient can become dehydrated to the point of developing acute hyponatremia. Similarly, if someone is running a marathon and having a very hard exercise and he's not adequately rehydrating himself, then with the loss of the sweat or the insensible water losses, this exercise can also trigger hyponatremia acutely, and the patient can have a lot of deleterious effects with that. And there are multifactorial causes apart from that, the important ones being thiazide and polydipsia, as we just talked about. All right, so what are the various clinical features that will tell us that the patient has developed acute hyponatremia? The number one thing is the patient will have the history of these symptoms present for less than 48 hours. And the important symptoms to understand is, as you know, that because of hyponatremia, the water moves inside the cells because from a higher concentration to the lower concentration. And this is specifically evident in the nervous system. So there will be generalized cellular swelling throughout the body, especially in the nervous system. And that can lead to a lot of nervous system abnormalities or symptoms, as we are going to see. Because of the movement of the water inside the cells, there will be a generalized swelling of the brain, and there will be cerebral edema and as you know, the brain is bounded by a hard skull, so there is not much space to expand. And because of that pressure, there are various symptoms and neurological symptoms that develop in patients with hyponatremia. So for sodium abnormalities, remember that brain is the one which is going to be affected the most. There might be acute hyponatremic encephalopathy. The patient might have, to start off, the patient will have nausea, vomiting, headache. Then the patient might go into delirium. The patient might be confused. And eventually, if the sodium abnormality is much profound and when the sodium levels are very low, the patient can have seizures or obtundation, and this can eventually lead to coma or death as well. So it is very important to understand the severity of the symptoms. And based on our treatment plans as well, the number one thing which we rule out in the treatment of hyponatremia is the severity of the symptoms. If the patient is developing seizures and the patient is comatose, or there are some confusion or delirium, then we have the urgency to act. And this is very important in the management as well, and to understand in the clinical features as well. Along with that, the basic symptoms, nausea, headache, and vomiting, these will be the initial symptoms, followed by the seizures if the hyponatremia is not corrected timely. And eventually this can lead to brainstem herniation and coma and death as well over a short period of time. So acute hyponatremia is a medical emergency, and we have to manage it very quickly and swiftly. We are going to discuss the treatment in the coming slides. As compared to that, chronic hyponatremia is hyponatremia which has developed slowly or greater than the 48 hours. The symptoms are generally mild. These patients can develop acute hyponatremia as well, but chronic symptoms are generally mild, and there is less urgency, and we have the time to evaluate the patient with the help of various diagnostic modalities. The important ones are vomiting and nausea. The patient might have confusion. The patient can develop seizures as well. And if the patient is seizing, then the urgency or the management of that seizures overtakes the management of the chronicity. So that I want you to understand that if someone has seizures, or if someone has a lot of delirium, or if someone is going into coma, then we have to treat that patient as a patient of acute hyponatremia. The management will be the same as we treat the patient with acute hyponatremia. Otherwise, if the symptoms are generally subtle, like someone is having a subtle gait abnormalities, or a few cognitive defects, a bit of confusion, and these patients are also prone to fall because of two reasons. Number one, there will be some cognitive abnormalities because of some problems in sodium. The brain is not functioning as a normal person, of a normal person. Similarly, their bone density is also reduced because of chronic hyponatremia, and this leads to a greater propensity to fall. So it is important to evaluate and treat this hyponatremia, because even if the patient is asymptomatic and his sodium level is low, this patient can quickly develop symptoms and can have a lot of deleterious effects. The patient might fall, and if he or she is an old patient, that can lead to a fracture, which might be very harmful for the patient in old age as well. So the various symptoms are overlapping, but the important thing is to evaluate the timing of the symptoms, the duration, whether the symptoms have developed within the 48 hours, and the severity of the symptoms, whether the patient is seizing, has coma, or obtundation. This is the time which we have to act quickly as compared to the other symptoms. Now, one important thing to understand is the Osmotic Demyelination Syndrome. This happens because of if someone who has come to us with hyponatremia, and we aggressively rehydrate the patient in a very smaller time period. For example, we give him the fluids very quickly, then that patient, after getting better in the next 1 or 2 days, can develop a condition called Osmotic Demyelination Syndrome. Because of overhydration, you have disturbed the water balance over a very small period of time. And this is very evident, especially in pons, a region of the brain, and because of that, the various symptoms develop. The important ones are, especially if a patient comes to you with hyponatremia, you have managed the patient well, and in the next 1 or 2 days, the patient develops these symptoms, then you have to classify that patient as the patient of Osmotic Demyelination Syndrome, or ODS. What are the important symptoms? Post admission, day 1 or day 2, the patient develops paraparesis or quadriparesis, or the patient has some dysphagia, difficulty in swallowing, or the patient has some dysarthria, difficulty in speaking. The patient might have diplopia as well. Any one of these symptoms can develop, or multiple symptoms can also develop. So whenever there is some neurological abnormality post the correction of the hyponatremia, the number one thing you should be thinking is Osmotic Demyelination Syndrome. The patient might have locked-in syndrome, in which the patient's eye movements are intact, and otherwise the patient is quadriparesis, and he or she cannot move his arms or legs to tell you about what is going on. The patient might has difficulty in speaking as well. The patient might be losing consciousness, or if apart from pons, the other areas are affected, like cerebellum, the patient can develop ataxia. Parkinsonism can develop if the basal ganglia are affected. And if there are other cerebellar abnormalities, the patients can develop dystonia and catatonia as well. So I want you to understand that post the correction of hyponatremia, any neurological abnormality, if you find out in the first or second day after the correction, then you have to rule out the Osmotic Demyelination Syndrome. You have to do the various labs, and eventually you might have to recorrect or overcorrect your treatment, and might have to induce hyponatremia by giving the patient hypotonic solutes like the dextrose water to get rid of this Osmotic Demyelination Syndrome. All right, what are the various labs which we are going to do that will tell us about the various types of hyponatremia? The number one thing to establish hyponatremia is the serum plasma sodium concentration. That will define us with hyponatremia. If we have established hyponatremia, then number one, first at presentation we have to rule out the renal failure. We do the BUN and creatinine. If the BUN and creatinine is raised and the patient has a history of diabetes or hypertension, then that patient might have chronic renal failure. If the patient has no history and this is developed acutely, then this patient might have acute renal failure. So BUN and creatinine are something which are available at presentation, and you have to look at these values. Similarly, you have to look at the potassium. In someone with Addison's disease or mineralocorticoid deficiency, there will be hypokalemia. As the body will be losing, there will be hyperkalemia because of less mineralocorticoid, the potassium loss will be less and there will be more potassium in the body. So hyperkalemia can give us a very good indication of whether the patient has mineralocorticoid deficiency or not. The serum glucose can give us a good indication, especially in the context of hypertonicity, or in someone with DKA who is losing a lot of water with the ketones and it is hypovolemic. So serum glucose is a very good indicator in that condition. Similarly, serum uric acid. In patients with syndrome of inappropriate ADH or SI-ADH, the uric acid is generally low. In other conditions like hypovolemia, when the body is trying to conserve the various solutes, the body tries to conserve uric acid as well. And that leads to an increase in the uric acid. So serum uric acid can give us a good idea of differentiating the hypovolemia or the normovolemic or the euvolemic hyponatremia. Along with that, we are going to look at the various endocrine markers like the thyroid to rule out the hypothyroidism. We have to look at the cortisol, we have to look at the ADH, and various markers along with that to rule out the various causes of hyponatremia. Now, just a quick recap of what we have talked about. This flowchart will tell you regarding the diagnostic evaluation in terms of urinary electrolytes and osmolality. In the absence of a hypervolemic state like cirrhosis or as we talked about nephrotic syndrome or cardiac failure, and the urinary sodium concentration is less than 20, this means that there is some non-renal loss of sodium and the patient is hypovolemic. What are the various non-renal losses that we talked about? We talked about the patient might have vomiting, diarrhea, there might be some insensible water losses as well, or the patient might be bleeding, has hemorrhage. Similarly, what will happen in syndrome of inappropriate ADH, because of an increase in the ADH concentration, the water will be conserved and the sodium concentration will be greater than the 30 millimoles, especially in the our urine. Because the kidneys will try, because of the other markers, the kidneys will try to compensate for the greater water condition to try to conserve the sodium. That will lead to an increase in the sodium concentration. Similarly, moving forwards, and this is also very good indicator that this will correct after the hydration with normal saline. Whenever we get normal saline, the correction of the sodium, urinary sodium excretion will occur. That gives us a good idea of differentiating the various causes from syndrome of inappropriate ADH. Similarly, there might be thiazide-associated hyponatremia. We have to take a good drug history of thiazide intake in the recent past. Similarly, the water intake history is very crucial to evaluate polydipsia. Because the patient is intaking a lot of water, the ADH will be decreased, and because of the decrease in ADH, the urinary osmolality will be low. The patient will be passing out a lot of water in the urine, and the patient will be passing a dilute urine. And in AVP excess, just like a syndrome of inappropriate ADH, the urine will be concentrated because of the increased ADH and great water absorption. The sodium loss is greater, and that leads to an increase in the urinary osmolality. And similarly, as we talked about here in syndrome of inappropriate ADH, the sodium concentration in the urine will be high, greater than 30 millimoles. And similar, and just as we talked about in someone who has a history of alcohol intake, we term that as a beer protomania. In those patients, kidney will, because of the dehydration, the kidneys will try to preserve as much sodium as they can, and the sodium concentration in the urine is generally less than 20 millimoles, and the urine osmolality is also very low because of might be as low as 100 to low 200s in these patients. So a good idea, urinary electrolytes and osmolality, urinary osmolar calculation and urinary electrolytes, especially sodium evaluation, gives us a very good idea of what is going on in the patient and the overall volume status as well. And based on that, on these calculations, we can establish the treatment modalities. Similarly, urine potassium concentration, especially in someone who has Addison's disease, in those the urinary potassium concentration will be low. And if we find a low urine potassium concentration and the patient is hypovolemic as well, we have to look at the adrenals, that whether the mineralocorticoids are working effectively or not. All right, after evaluating all of this, let's look at what are the various treatment options we have for hyponatremia. I want you to keep number one thing in mind in regards to treatment of hyponatremia is that urgency in correcting the plasma sodium concentration effectively overtakes every other thing. If we have someone who is presenting with symptoms of hyponatremia and life-threatening symptoms like seizures, coma, or obtundation, then that is an urgent matter and you have to treat that as an urgent condition, whether it is present acutely or whether it is developed in someone who has chronic symptoms and superimposed acute development of seizures in that patient. So anyone who is seizing or anyone who has obtundation or is going to coma and has low low plasma sodium concentration or has hyponatremia, you have to give them hypertonic saline. You give them hypertonic saline to correct the sodium abnormality as quickly as you can. But this is very important to understand that you just have to correct the sodium abnormality by about 4 to 6 millimoles. That if someone has 130 or 128 sodium millimoles of sodium concentration in the plasma, you try to quickly raise the sodium concentration in the normal range around 135, and then afterwards you manage that patient as a patient of chronic hyponatremia, which we are going to talk about in detail. So urgency overtakes everything else. The other thing is which is important is to look at not to overcorrect or not to very quickly correct the chronic hyponatremia and to avoid the development of osmotic demyelination syndrome. And number three, we have to look at the various treatment regimes, especially in the context of SIADH, and that if one is not working, then we have to look around the other regimes. So number one thing, if there is urgency, give the patient hypertonic saline, try to correct the sodium as much as possible. Preferably 4 to 6 millimoles is enough to stop the patient seizing. Afterwards, when the patient is not seizing and has normal symptoms or the patient is asymptomatic, then you have to look at what are the underlying causes. Just remember that flowchart which we discussed in the causes of the hyponatremia, we have to rule out the causes one by one. If on the volume assessment we find that the patient is euvolemic, then again the mnemonic I told you, RATS, R for renal tubular acidosis, A for Addison's disease, especially secondary Addison deficiency, T for hypothyroidism, and S for the syndrome of inappropriate ADH. We have to rule out or look at these, whether there is any thyroid abnormality, whether the cortisol and the mineralocorticoids are in normal concentration, and then we evaluate them. If we give the patient thyroid and hypothyroidism, or we give the patient cortisol, then the plasma sodium concentration increases and it auto-corrects itself. SIADH is a complex topic because there might not be a lot of reversible cause of SIADH. If it is because of any drug intake or any pulmonary abnormality or any nervous system abnormality, then if we get rid of that abnormality, for example, if the patient has pneumonia, and if the pneumonia is treated and the patient's overall sodium concentration increases, then so be it. But if it is resistant or not reversible, then we have a lot of pharmacological options available for SIADH. For example, number one, we might give the patient furosemide or loop diuretics to get rid of the excess water along with the sodium, and loop diuretics are very important in the treatment. We might have to give patients some sodium tablets or increase the sodium intake. And along with that, if these treatment modalities are not working, then we have certain drugs like demaclocycline, which act at the level of the kidney, and they are the ADH inhibitors. Similarly, for the treatment of chronic hyponatremia, we have ADH inhibitors in the form of veptans, like the called Web10 or various types of Web10s which nullify the effect of the ADH at the level of the kidneys. So these are the various options, and we have to increase them step-wise step. We start off with water restriction, which is very important in these patients. Then we ask them to increase their solute intake, especially sodium. If that fixes it, so be it. If it is not fixable with that, then we proceed on to the drugs. We start with the loop diuretics. If that doesn't help, then we might go on to the dimethylocyclines, or afterwards we might help to give the patient Vap10s or the ADH inhibitors. So it's a stepwise progression of the treatment of SIADH if it is not reversible because of any underlying pathology. Now, if the patient has hypovolemic hyponatremia because of loss of anything, loss of blood in the hemorrhage, or because of vomiting or GI abnormalities, mostly these patients get better by the infusion of the isotonic normal saline. And whenever we give isotonic normal saline, the patient have a lot of diuresis as well, because the ADH levels go down in these patients, and overall hyponatremia fixes itself very nicely in these patients with hypovolemic hyponatremia. If someone with hypervolemic hyponatremia, for example, someone with liver cirrhosis or heart failure, we have to give ACE inhibitors. We have to increase their concentration as well to, for example, patients with heart failure, to increase both the afterload and the preload to have an effective circulation. Similarly, we might have to give these patients loop diuretics as well to overall decrease the edematous state as well, just like the management of edema, in which we talked about the various treatment modalities for cirrhosis and nephrotic syndrome and heart failure as well. And if the hyponatremia is due to beer protomania or because of decreased solute intake, in those patients we give IV saline, and eventually the patient, when the overall homeostasis is established between the sodium and water, and the patient has resumed a normal dietary intake, then those patients generally get better with the help of a normal diet and after the acute phase of management with the IV saline. So this is an overall good flowchart to understand the treatment modalities in the management of hyponatremia. Just one important thing, how to calculate the free water clearance. This is the formula I want you to remember. The free water clearance is equal to volume multiplied by 1 minus urinary sodium multiplied by the urinary potassium concentration divided by the plasma sodium concentration. If someone has positive free water clearance, that means that the patient has positive free water clearance means greater than 1. That means that the patient is excreting a lot of dilute urine. And if it is less than 1, then the patient is secreting a concentrated urine. This is not very important in the context of the treatment of hyponatremia, but it is important to mention here to just if we want to calculate the tonicity of the urine very quickly with the help of the labs available. This will be more relevant in the treatment of hypernatremia when we are going to talk about in the next lecture. So just wanted to mention here too, so that when the next time when we discuss this free water clearance, this might sound something which is familiar to you, and it's not something which you have heard about for the first time. With that, we conclude our lecture on hyponatremia. I'm going to see you in the next coming lecture in this series of lecture on fluid and electrolyte abnormalities. That's for all today, and thank you for watching.